So why don't we get started? And the others can join. And for the good of the cause, let's go around and introduce ourselves. So maybe Liz, you can start.
Sorry, took me a second to hit the mute button. Liz Blackwell-Moore, she, her, and I'm the Director of Public Health at Cumberland County.
Excellent. Ella.
Hi, I'm Ella. She, her, I'm in the Attorney General's office providing administrative support and working as a research assistant.
Great. And Pat.
Hi, I'm Pat Kimball. I am currently retired, recovery ally, and am chair of the Recovery Council.
Great. And Haley.
Haley Tranco with the Attorney General's office, she, her, doing administrative work for the Recovery Council, not a council member.
Great. And I'm Joe Everett at the Opportunity Alliance, and I'm a member of the council and a member of this committee. So welcome, everyone. So why don't we start by looking at the minutes? Any questions or comments from the minutes? Haley, do we need a motion? Do we need to approve
Actually, I don't think that we have a quorum for the committee meeting yet, so I'm not sure we can do anything without anyone else joining us first.
Okay.
Let me see if anyone's stuck as an attendee and needs to be promoted. Doesn't look like it, but we do need at least, I think, 5 committee members to make a majority.
Okay. So why don't we jump through the agenda and we can move around. So I think at the full council meeting, I know there was a lot of conversation about priorities. So it'll be great today. And hopefully we have more members join so we can sort of talk about specific priorities and maybe priorities by area. I know Chastity had questions about harm reduction when we did around the round robin at the meeting. So I hope we have time for that. And then why don't we start with the survey, Liz? Any updates or anything you want to share with the committee?
Yeah, we got all the translations. We have we're inputting it now. It should be done. We're finishing it this afternoon, and we're gonna test it this afternoon just to make sure that it works how we want it to work. It's a kind of a complicated survey on our end, and then we are sending off the link to Haley, and we are going to group them all together in one document, as you probably saw, that's all the multiple ways that everybody can have input into the work of the council. So that's great. So if everything goes according to plan, it'll be going out with the communication that's going out around the forum, the public forum. So tomorrow.
And that should go out tomorrow, yeah.
Perfect. Welcome, Gordon. Do you want to introduce yourself to the group for the good of the cause?
Yes, Gordon Smith. I'm the state's director of opioid response in the governor's office. Sorry to be late. I had a little trouble signing in through our bureaucracy, but happy to be with you.
Well, we're happy to have you. And okay, anything else, Liz, on the survey before we move on?
I don't think so.
Excellent. Great. Is there any needed conversation about the public hearing? Pat, Haley, Gordon, comments, questions we want to talk about?
So Haley nicely synthesized all of our comments, and that there should be an announcement that we'll be able to push out, should be able to go. The only real question was, and I sort of made a decision. There was some talk about asking everybody to come with 20 copies of their testimony. I just think that's a waste of paper. I think if they come with 1 copy, we can scan it and then send it to all the membership. But we're asking somebody to bring that's what they do at public hearings for the legislature. Not everybody has has a copier sitting in their house. Plus the fact, if you haven't seen the price of ink for printers, it's so expensive. So I think that's what we'll do. And on the public hearing, we have the place, the time. I think, again, we just got to get the membership to push it out. And on that survey, on that announcement for the public hearing, we will put also on there the link for the survey. So there'll be a link to put in for the public hearing, to send written testimony if you don't want to come in person. And then there'll also be a link where you can complete the survey. So we'll get double that. But other than that, I think we're moving forward with the whole thing. And I really want to thank Haley and everyone in the office for at the Attorney General's office for helping us with that. So we look like we're going pretty well.
Excellent. That's great. Welcome, Miles. Oh, go ahead, Gordon.
Yeah, welcome, Miles. I just wanted to comment on what Pat said about the 20 copies. Another reason not to require that is that we don't want this to look like the legislature. We're not the
Right.
legislature. That's why it's good that we're not at the State House. And the 20 copies thing, that's just a legislative thing. The legislature does it. We don't need to do what they do. So I love the approach that you've described.
Yeah, me too. It's great. Simple and hopefully low barrier, and people can show up and impart information without a lot of red tape, so to speak.
And if
Miles, do you
everyone-
want to introduce yourself just for the group, for the meeting?
Yeah, my name is Miles Willett. I'm a clinical supervisor at an outpatient treatment facility and someone in long-term recovery. Sorry for being late, folks. I was having trouble getting on, and I have about a 45-minute commute from work to home. I was trying to make sure I could not have to stay in Presque Isle longer than I had to. So thank you.
Great. So why don't we move into sort of a conversation about priorities? And it would be great to just, at the council meeting, we were sort of popping around the table, but I think it would be great to have sort of the perspective of the committee members as it relates to sort of what we see as sort of boots on the grounds in terms of priorities. So I know, just that I didn't write everything down at the meeting, but I know, Pat, you had mentioned families. Liz, obviously, prevention was, there's lots of conversation around that. Treatment, there was talk about expanding treatment beds. So I'm taking notes in Chastity's stead, so I'll do the best that I can taking notes so we can reflect it back. And then welcome, Kim. Kim, do you want to introduce yourself? Welcome to the meeting.
Sorry, I was having a hard time unmuting. Hi, Kim Johnson. I'm working as a consultant on this project to help you figure out what you're going to spend your money on. So I'm here and I'll take notes as well, Joe.
Perfect, great. So with that, I'd open the floor to just a conversation about what we see as the priorities that, that we're experiencing and living and seeing in our communities. So I open the floor.
Well, I'm never bashful. You have the governor's strategic plan, but I grant you that's 34 strategies, 9 priorities, and dozens of activities. I've said consistently for a couple of years that I still believe that the highest need is beds. Going deeper into that, it's really beds for short-term, for medically supervised withdrawal, the kind of beds that we have at Milestone, frankly, in Wellspring and Hamden. But also equally important is having a good residential facility for people who successfully complete their withdrawal. And then whether that residential treatment is 30, 60, 90 days, I'm certainly not talking about 28 days. I mean, something substantial, and recognizing that not every individual in this situation needs residential care. We have IOP, we have, it's everybody's individual journey, but many of them seem to need residential care. And we haven't had enough beds probably ever. We certainly, as we've seen increasing use, increasing numbers of people, perhaps through the pandemic, we lost some beds. I'm a firm believer that we don't have enough beds. Now, having said that, the state has prioritized that, and we do have 140 to 170 probably beds on the way. Some are opening this month. Some could be another 6 months. So we want to take that into consideration. But even with those beds, I really think there's a fairly urgent need. The number of parents, people directly using that call me and have been to 15 emergency rooms and called 20 places, and no one will take them as a patient. That's heartbreaking, particularly if they die the next day while they're on a waiting list. So I think that's all I want to share right now is that beds, and then the list. I stand by the list that of priorities and gaps that Director Squirrel shared. I think there's 6 things on that list in priority 1, and now there's a couple new things on priority 2, and I'm not even sure we've seen those, but I do stand by the work that we do every day and the gaps that we've identified. Thanks.
Just to piggyback and give you folks some perspective. Hi, this is Miles Willett. Right now, as of this morning, I made a phone call and a referral to Well Springs. There's a 3-month waiting list as of this morning. 3 months. So like Gordon said, a lot of folks don't make it there. Something else too, it's a priority for me is building a workforce infrastructure, because we can create all of these beds and we can create all of these things, but we are short-staffed everywhere in Maine, but especially for substance use counselors. Counselors have caseloads of over 100 to 150 patients, which I know there's a waiver out there, but that shouldn't happen, but we have no choice. And the state's been great with the state's been great with having, what we're doing, but it's not working. So, when I was going to school, which is not super long ago, but there was nobody that came in that, it was discussions of, being a doctor or a lawyer or a police officer or a welder, but nobody came in and spoke to schools about becoming a substance use counselor. So I would put my right arm that if we created some sort of program where folks went into high schools and spoke about this, or even you had one person, we double or triple the amount of applications to Beale College, to Washington County Community College, to UMA, the programs that offer the substance use program. If we can let them know you need 1 year of education and you can make X amount of dollars, things like that. But we need to build an infrastructure of workforce development. And I know that we've been working on that with the workforce development grants that have come through the last couple of years, and that has helped. But I think we need to do a little bit more. Thank you.
Wouldn't it be nice, Miles, if we saw the community colleges here in Maine, because there's a shortage of welders and technicians and some healthcare things. We saw that tuition being waived. People can go to community college now free for 2 years. Wouldn't it be amazing if we could offer free tuition for people going into the field? But then we also have to look at seriously the pay structure of substance use counselors. It's really hard for people to come into this field and take that rate of pay and be able to sustain above the poverty line. I mean, it's pretty bad. And what's really sad is I'm listening to Gordon's conversation and your conversation about Wellspring and a 3-month waiting list. I retired 6 years ago with a 3-month waiting list. So again, it's about moving forward, but you do have to have a workforce. So for me, one of the priorities is, again, I said families, but the other piece, at some point in time, I'd like to have a conversation about is that the state has put before us some programs that fit into our MOUs, which include the expansion of beds, which includes mobile units, which includes crisis centers, prevention work, all of that. And for me, how do we get that on the table to have a serious discussion with the state as to exactly how much money are you asking for and how are you going to put that money out there? And so right now in my head, it's sort of a short-term priority. I mean, my long-term priority always has been about families because I do believe they're a neglected um, uh, piece in all of this. And where do they go for help? Even those who have members of their family and loved ones that are actively using, Gordon knows that. That's the biggest call they get. Where do they go? We certainly are really good at sending them, telling them places they should send their family or their loved one. But where do we send them? And they certainly have had some trauma in their lives and could use some support and care. So those are my thoughts on that.
Welcome, Kina. We're just talking about priorities, and you want to introduce yourself just for the good of the cause for the meeting?
Yes, thank you. And I apologize for being late. I was seeing patients. Yeah, Kina Thakrar, infectious disease and addiction medicine doc. And thank you.
Great. And Liz, your hand was up.
Yeah, I just want to say that, of course, my priorities are to do some things immediately that are similar to the ones that you all have talked about. Increasing the medical withdrawal beds, crisis centers, doing the work to make sure we have enough beds for folks right away. I guess I want to, because we're constantly have wait lists, we're always need more people to do the work. The thing I want to make sure we keep in mind, and I know I've said this a million times, but is that we should be doing parallel processes, doing prevention work and using this funding for prevention work. And I think I see kind of three places that I think this money would be particularly useful. One is really doing community level work, like going to the communities that have been most impacted with some level of an infrastructure for supporting prevention, harm reduction, recovery, and like the continuum of care. In New Hampshire, they have a person who sits at each public health department whose job it is to hold the continuum of care from prevention through recovery and be a coordinator and a connection between those things, because it provides an infrastructure for ensuring that they're connected and that we're doing all of it. So some level of infrastructure and really direct support in those communities. And it may be that it's basic needs that people have, like they need money for rent, they need it may be that there's really basic things that need to happen there. I think also having tiered behavioral health services for young people, like you mentioned, Gordon, there are young people who end up with they have a behavioral health crisis and they end up in the emergency room for weeks on end. Those are young people that now are at greater risk for substance use disorder later. So having tiered support services for young people is good long-term prevention. And then 2-generational prevention, really doing prevention with families and early interventions with families who've been most impacted by substance use disorder. So really thinking about how do we beef up the resource navigation and the supports for families that have been super impacted, and doing direct prevention work with young people and their families. And it may look really different across the state, but I think we're gonna need to spend some money there, and not just on blanket statements about not using drugs and not, about the harms, but really digging in deeply to trauma that people have had in their lives, to the systems that aren't working for them and have caused trauma as well. And how do we really support them to get out of those situations before they become, have a substance use disorder. Thank you.
Great. So just a question I have for Gordon and Miles, sort of with regard to the beds that are available. And I know that Dr. Squirrel gave us the list of the kind of who's open, who's in queue. Are those beds easily accessed by all the people that we're trying to reach, or are there limitations? I think some take main care, some don't, but are there barriers to the existing, short of the need, which is huge, but are there barriers that you're concerned about, Gordon? I'll put you on the spot. Or are they pretty accessible, clinically speaking, and insurance, et cetera, et cetera?
Well, number one, they're not all up. They're not all open yet. Number two, I only know of one facility that we're working with that's restricted to private pay and commercial insurance, and that's Liberty Bay, and that's well known. I mean, they provide a valuable service. I know the medical director over there, but now they're owned by a larger organization that actually provides Medicaid services in New Hampshire. So I don't understand why they can't. What's wrong with our money? But so I actually believe that all of the things that we're supporting with state money, they have to be available to everybody. And we not only support them with main care funding, but also the Office of Behavioral Health spends millions of dollars on the uninsured piece that goes along with that for people who aren't eligible for main care. So I don't believe that the lack of insurance and that main care, I believe that I actually believe that in time we'll get Liberty Bay too. But there are other barriers, of course. Transportation, would be one that absolutely comes to mind. And where the facilities are they, that's tied into transportation as well. But like we have now 100 recovery residences, 78 probably certified, but we have 0 in Hancock County. We have 1 can handle 5 women and their children in Chias, 1 in Washington County, 2 miles in Aroostook County. So a huge swath of the state. We only have, don't have anywhere near enough recovery beds. So I'd say the barriers are now, not enough of them, and transportation and location.
Yeah, I would agree. And on a clinical side, from the patient, person, member, folk, individual, stages of change are a barrier. So that level of where someone is at in the recovery. So if they don't have this bed available, there's this 3-month wait list. Someone is ready for that change now. Within a week or 2, that could change. Within a month, that could change. So with those, those other barriers that Gordon mentioned. However, the state has done a phenomenal job. I don't want to say money is not really a thing, but if someone needs to get main care and they can't, I know personally I've seen over 2,000, and I'm probably under, but uninsured OHH slots for folks for that lower level of care. Maybe someone needing MAT. You can go almost anywhere in the state of Maine, same day, next day, and get an appointment to see someone for MAT, whether that's methadone, Suboxone, Sublocade, almost anywhere in the state of Maine, same day, next day. But to get that bed, that's the difficult part. And then we only have so much money. So like all these things sound great. We only have so much money. I know 14 million sounds like a lot, but really it's nothing. So that's, I guess, the hard part is where do we put this money that's going to be the biggest bang for our buck? I think that, like what Pat mentioned, I don't agree with everything that the state has going on in the strategic plan, but a good 75 to 80% of it I do, and I'd be willing to back the state and figure that out if they already have something going. They already have a plan. We wouldn't have to reinvent the wheel. We could add a few things, take a few things out. But that's, I agree, Pat, I think that would be a great idea, figuring that out.
Yeah, I mean, we don't have to do everything. To piggyback off of, what Miles is saying, one of the things, and again, I've been retired for a few years, but things haven't changed. I mean, one of the things is how to create something that if you're on a wait list, say for instance, you meet the criteria to be in a residential treatment center and you're on a wait list, what are we doing for them while they're on the wait list? I mean, that's, do we help agencies be able to say, well, you're on our wait list, but we can offer you this medication, We can offer you a group. We can, how do we, again, what are they doing while they're sitting on the wait list, which has always been a question of mine. I'm going to age myself, but Kim knows it. Years when we did the NIATEX, sometimes the perception of what's available for beds, like I hear all the time, agencies don't only take Medicaid, or they only have this. And sometimes that's a perception and not really if you dig deep into it. For instance, I can almost guarantee you that wait list is 3 months old, that you wait 3 months, but those beds move quickly sometimes. And so sometimes what looks like a long wait ends up with a shorter wait. So again, I don't want to get into the philosophy of that, but I do think at one point in time, it would be great if someone would invent a way to take the people on the wait list and be able to say to them, that bed isn't available for you, but this is what is available for you. And how can I not say, here's a card, go call them, but let me call you right now and get you and sit with you and get you to an MAT or something that's available. Anyways, that's just a thought.
Well, can I just mention, we have a public safety grant right now that created a system in which there's a resource navigator who sits at the Portland Recovery Community Center. And in the last 6 months, that person has worked with 140 people to help them find treatment options, but also resources in general. And then we've paid for 1 month of recovery residence for them with the money. And with that, we're adjusting as we go. They're adjusting as we go to see about making sure that we're like doing enough to keep people becoming really successful, as opposed to like meeting all the need, like everybody who walks in the door. But 140 people in 6 months, I wonder if there's maybe that's a model that's being used across the state, but a resource navigator model. They're not a case manager, they're not a clinician. There's somebody whose primary role is just to sit with somebody, help assess their need, and then help identify resources for them and do that. And then of course it's helpful when they have money to pay for recovery residence for 1 month. But it's a model, and maybe it's already happening in other places, but it seems like there's a lot of need for it.
So part of the OHH, sorry, Gordon, part of the OHH requirement, and I think this is probably where you might have been going, but so for folks that are on MAT, which is probably anywhere between 5 and 10,000, maybe a little bit more in the state of Maine, but these companies have to have a resource navigator. They call them patient navigators, but that's their sole job, is to connect folks to resources. So there is something in place now. I don't know exactly, I know as a clinician, we used to do part of that work, but then when they created the OHH and the team, they have a lot of patients, the resource navigators, but there is one, like, I'll say for groups, I used to work for groups. There's 16 offices in the state of Maine, and they have, I think, close to at least one in every office. That's what they do.
Well, so they have to be in treatment to get access to that resource navigator, like on medication, or can anybody access that person?
They have to be on medication, part of that program, but there are other programs out there where you don't have to have MAT. If you're part of that program, you can get those same resources, but that's a requirement from the state, is that they have to have patient navigators, I believe. And Gordon, again, I know your hand is raised.
Well, I think that's right. The OHH has a number of requirements, and that's probably one of them. But that's all outpatient stuff. But yeah, and you're right. Miles and I have talked about this before, that we do have pretty good access to outpatient medication treatment, even in the rural parts of the state. Liz, the project that you're talking about really is just the current model of Project Hope that started in Scarborough. It's just, we moved, instead of people turning in their stash and getting sent to treatment from the police station, everybody felt that, well, they'd probably attract more people and probably be more comfortable coming into a recovery center. So one of the nice things about that is that we're going to have 21 recovery community centers. So I want to talk for just a second about shovel ready, the problem in identifying our priorities, that we don't want to overemphasize those projects that just because they're easy to put up. Beds are easy to put up. Workforce is difficult. So like the things that I identified as priorities, not easy, they take a while, but we know how to do them, because I can go to a group that wants to invest in me and say, look at what Milestones is about to do here on Andover Street. I want you to do this with 10 detox beds in Machias. We know how to do it. The Project Hope things can be scaled up because we know how to do them. Some of the things that have been described, and they were incredibly important, the three things that Liz talked about and Miles talking about workforce. I don't know the project. I don't know where you start. All I'm saying is that it's going to take more strategy and more looking around the country, if you will, or because, and that's why, you put out a good RFP, because somebody will come in with a good project. So maybe all we can do is identify and say, we want to put $5 million into workforce, and we want to give priority to things that can be done, rapidly as opposed to 10 years from now, and come in and tell us what you can do with some of this money to give us people that can work in these facilities. So I just want to acknowledge that the ease of the project is going to be something we're going to struggle with, I think. Some things we don't really need to probably put out an RFP. We could sole source some things. We know what to do. But other things that are more, they're not vague. The need is what Liz has talked about are incredibly important. But what projects do we have that have shown an ability to deal with multi-generational drug use in families? All right, I've said enough. Maybe there's some answers that some of you have.
So I was trying to find my raise hand button. So there are some, Gordon, and one of the things I can bring to the next big meeting is sort of a list of like what has good evidence for on all of these: prevention, harm reduction, treatment. One of the questions I have, though, can I ask this, Joe? Am I allowed
I think
to?
Keena's had her hand up for a long time
Oh,
now.
thank
Sorry,
wondering
Keena.
if you have her
That's
hand
okay.
up.
No, thanks, Liz. Yeah, I just wanted to say, I mean, I agree with everything that's been said. Absolutely. Like Liz, the prevention piece and low barrier treatment beds, these are all important. I just wanted to make sure also, funding harm reduction is still going to be really important, especially if folks are on the wait list. That's my concern, is that people are waiting and we really need to keep folks alive, right? And also reduce the morbidity that we're seeing. I think I mentioned this at the last meeting, but we have the highest rates of acute hepatitis B and C. I was on call yesterday, got called on, a hepatitis A outbreak patient, which we're seeing really affect our unhoused population. And so I think that you just don't want to lose sight of that as well. And in talking to some, syringe service program colleagues, even just yesterday, I think that, if people are waiting for beds, many folks are not injecting, they're smoking. And so we really need to recognize that, and also make sure that we're funding things like safe smoking supplies and all of these things so that we're reducing infections and still reducing overdoses while we're figuring out this workforce and bed situation too. So that's all. Thank you.
And I'd love for us to talk a little bit more about harm reduction strategies And then we'll go back to you, Kim, though, and then let's come back and talk a little more about harm reduction at the group.
Well, and what my question might actually sort of bleed into that anyway. So I'm interested, you say that it's pretty easy to get medication like within a day or two if people want it. And if you were to pick anything on the list of things that have the most impact in the medium term on overdose deaths, medication for treatment would be like the thing. So and your deaths are coming down. So that's, maybe that's an indication of that, but I'm sort of wondering like why, so you have easy access to meds, but it doesn't seem to be having the size of impact that one might think or that you might want. And so I'm just wondering what you all are thinking about, like why might that be? Like what's missing in that one thing?
I don't know that people that reach out to us, like I'm talking people who need service, but family, friends, which say there's easy access to meds. And maybe that's an information issue, maybe it's a lack of, but I think that people, and I might raise this, as my priority, Kim, last month when we were together early this month about sort of med management. We've asked people like board members' kids, are like, where do we get this? And we have a hard time to find them, or they are having a hard time to find meds. So maybe it's just information. And Liz, I don't know if you can say any more in Cumberland County, what we're experiencing from your seat, but that's just what I hear, sort of it might be easy accessible, but I don't think people really often know where to go.
Kina, I'll let you answer. I feel
Oh,
like
sorry,
you
Kina.
know.
Oh yeah, that's okay. Yeah, I was just gonna say in terms of the treatment access, I mean, I think it's great that we have more buprenorphine prescribers, but I think for methadone, again, like I'm not an OTP, clinician, but I mean, my understanding is there are still, a lot of wait times, the transportation barriers, obviously there's some federal regulations, right, that we are up against. There's obviously this whole movement to deregulate methadone, which I think needs to happen. But I think in the era of fentanyl, especially, I think this is also contributing, the lack of access to methadone treatment, in addition to other things too.
I've also heard, because of the complication, like the complicated polysubstance use is making it really difficult. People have to go through medically assisted withdrawal in some cases because their substance use disorder is so complicated before they can access some treatments. And also, I just think I keep hearing that the treatments need to be more tailored to this very complicated substance use disorder that people have. Maybe you can speak to that, Kina, but I think there are people can access the treatments if you can have a transportation and you have a safe place to then to live. I think the housing situation, like for us, that's the piece that's bringing all these folks. They have the medication, they have the case management, they have the, support services, but they don't have anywhere to go that feels safe while they're now trying to live in a different way and in recovery. And so us being able to have that funding from the state to provide just at least a month of recovery residence and a safe place to be, I think is really monumental for them. And it's the same. We have a reentry grant as well out of the jail that provides recovery residence support to 100 folks. And I think most of them will say that's what makes the difference, is having a safe place to go for their chance of success.
And does that stem back to a workforce development that says if I'm a clinician and I have 100, 150 people on my caseload, am I giving people the treatment time that they need in order, particularly in early recovery? And again, if I've got 100 patients, I'm not giving them what I think, and I was a clinician for many years, am I truly giving them what they need, particularly in early recovery, to be successful, to move forward when I have 100 people on my caseload, unless I'm working, 24/7. So again, it sort of stems from why are clinicians having such large caseloads? And if they are having these large caseloads, is it just because of some regulation, or is it because there's no one to do the job?
So I just want to go back where Liz started at the beginning of the meeting around sort of like basic needs and food. And I think that TOA, like we're really trying to delineate, you know, OHH staff, clinicians is about medical necessity, especially if you're getting funded through Medicaid or main care. So I think, Liz, to your point, to this conversation, there's such a need for these resource navigators. Because when a person comes in and they have no food, no real support, no place to go, they can't do anything. They're stuck. And then we have prescribers who are in it with them, trying to like get them those sort of needs. And I think it's sort of like using the right level of staff, like this staff does this, and then all the way up to the prescribers. So right now we just see people everyone's scurrying and scrambling. And I think across the state, if not the country, to sort of like meet those needs. And I think we're not moving the needle with helping people get to where they need to be, because we're so focused on these other really intense unmet needs. Liz.
And I just want to add that I think there are ways to take a similar model and put that at the prevention end. So I think to your question, Gordon, of like, here's my worry. We allocate a whole bunch of money to all this other stuff, and we don't get to prevention, and we don't do it up front because it's too hard, or because we don't have the right answer the second. And I worry that then it gets lost in the recovery funds completely, and that we don't get to it. Because I've watched that happen. We've all watched it happen for 40 years, that prevention gets about 1%, generally speaking. And so I would hate for this to get 1%. And I know you all aren't going to let that happen, and I'm going to keep talking about it. But I think that that's why it has to be something that we allocate the funding for, and that perhaps we allocate it for, like, I think we need to do outside of some of the things that the state has said they want to fund. The things that I think that are not on there are some of the innovative things that we need to innovate on and figure out how to do. And if we can allocate a little bit of funding for that, to have some folks do some deeper work in community. This is what we're doing with our money, is we are working towards now moving into going to folks in community to say, and do some participatory, work around, like, what do you think we need to be spending the money on for those communities that have been most impacted, or the families that have been most impacted. So allocating some funds for coming up with those two generational approaches. They already are happening through some OCFS funding. I know, at Opportunity Alliance, there's some of that work happening. And I think there's ways for us to just seek it out, and then seed money. It doesn't have to be huge money, but seed money to figure it out over time. That is kind of the beauty of 18 years. If we decide, and this doesn't have to be the short term, like a ton of money, but I don't want to get it can't be lost here in this initial, because if it's lost initially, we will never find it again. I can tell you, we won't.
Liz, are you already getting some stuff from the communities that are affected about what they think they need?
Right now we're hovering around talking to the folks who work with those people. So that's kind of where we're starting, because we are going to move in deeper to the communities most impacted, but we want to do that thoughtfully, with a trauma-informed approach, so that we aren't promising things we can't do, or asking people to tell us again for the 80th time what they need when we have some. So we're moving in that direction, but we've just kind of allocated it to that work in the last month. So when we do it, though, I'll be sure to share.
So I think that something we haven't really discussed too either is that there's more money out there. So when Liz, when you talk about prevention, and I'm thinking like, all right, so how do we do this statewide for each county? So we do have money coming into each county every month. So how can we leverage our expertise and our plan to work with, it's something we talked about right at the very beginning, but work with the counties that have, I don't know exactly how much each one has, but they've got a decent amount coming in, and how can we, in the long term, build a prevention program, or like you're talking about, in each one of the counties, and to try to get them on board, because we haven't even really discussed that at all. And they've got quite a bit of money throughout the state. I mean, we've discussed it a little bit, but it'd be nice to be able to leverage what we have and our ideas, and not share the money, but just to be able to use it in each county.
Well, I think there is a way to do that, Miles, and a very simple way would be to let them prioritize what their needs are, but to offer them a matching grant. If they are collaborative, they report results to us, and we could say, we've got X number of dollars ready for any county that, under the following criteria, will submit to us, an application for a project that's important to their community. So I do think that we want to use a carrot and not a stick approach. We don't have a stick. Honestly, we don't have much control over these county monies. But not only the 16 counties, but the 23 municipalities. It's not a ton of money they have. The bigger counties, of course, might right now have $1 million, but the smaller ones might have, $90,000. But I really thought that was a good approach that we've learned other states have done to offer them a matching grant. Match doesn't have to be 50-50. Could be it could be 20-80. It could be 80-20. Whatever fits that situation.
Well, we're the largest county and we only have, we get about 210,000 a year.
Yeah.
So it's not, we have a town that's getting 2,000 a year, and they've decided to give us the money and go in on it with us, because it's too hard for them to figure out what to do with it when they don't have the resources. But actually the towns in Cumberland County, some are using it to fund behavioral health liaisons, but some are using it as like funds for the behavioral health liaisons who are already paid for through their police departments to use to support people who they are engaging with, whether that's in they're through harm reduction approaches, or through helping them stay in a safe place for a couple nights while they then find the resources. So they're using it as sort of emergencies for people with substance use disorder. So, I mean, people are using it, like all the ones I've talked to, it's been, super legit. Like they're using it for their prevention things that are already working and going well, but they want to expand those, or they're using it for, this stuff for meeting emergency needs, basic needs, while they wait to find the other things that exist out there. So they're using it for legit stuff.
Yeah.
Well, we can also throw in that mix that part of this money has to go to the schools. There's a portion, is it 3%?
It is 3%.
And that money is specific for special education. So it could be other money, we could be going to them for other things, because we've asked the schools to essentially do all this work around behavioral health and supports. And they are like the front lines of prevention work, and they could use some more support for infrastructure, for doing a lot of the work that's happening with families. But that needs to be outside of that 3%, because that 3% has to be for special education.
I'd have to relook at the definition, but that may be loosely defined.
No, I think
Is it pretty specific?
I think Liz is right. That 3%.
Because there's also language in there about a recovery high school.
Oh, sure.
So there are things in there that says you can open with the funds a recovery high school.
Sure. We could give 100% of the money to schools. I mean, so the 3% should very much, I think, be considered a floor, not a ceiling. We have to do that much for special education. We have to hire a consultant to help us do it. and the schools have to have an opportunity to apply for that. But that's just for special education designed because there's a belief that people with substance use disorders who had babies, that some of those could have developmental issues. Some of that's true, some of it may be overstated. But that doesn't mean that we can't do all kinds of other prevention work, including a recovery high school if you want to. Yeah. And remember that a lot of the counties, by the way, are using some of their ARPA funds, not opioid settlement funds, but ARPA funds they have left over. They just, Bangor City Council voted 5-2 the other night, give $670,000 to have a crisis receiving unit at Health Equity Alliance. You read the story in the paper very recently about $35 million from the York County Commissioners to do their facility in Alfred. So those are all very helpful and don't come out of opioid settlement fund.
Yeah, in Cumberland County, we supplied money to Milestone to purchase their building for their new building and expansion of beds.
So we're getting down to the wire, and I do want to approve the minutes now that we have a quorum, I think, Haley. But sort of just some quick thoughts about sort of wrap up and next steps. And I know we didn't really get to harm reduction, which I really wanted to, so we can talk more next month. But any sort of threads that we can thread together to wrap this up to sort of keep moving? And Kim, as any wisdom you have would be great too.
Well, so I'm still sort of struggling with how does this conversation get incorporated into the conversation with the larger group? This is very similar to what I was thinking we would have next month. And so that's just a question I have, which maybe we don't have to talk about now, but
no, great point. And I look at our fearless leader, Pat, after last month. Pat kind of took the meeting by storm, and she sort of sent out sort of questions about priorities. So I think if I could I'll work on getting the minutes quickly out to the group so that maybe Kim and Pat and others, we can sort of like formulate kind of what we're talking about. And I think there is alignment with and I have, Jordan, that document I'm looking at in front of me, the 6 priorities. And I think Liz laid out some prevention ideas, the 3 other strategies she mentioned. So I think if we could look at those and try to build that out to come back. And I think people like here sort of like, my hope today was to have a boots on the ground reality conversation and then try to find alignment or crosswalk with the DHHS Dr. Squirrel's projects that got presented to us, because these have been thought out, I believe. So if we could take today's conversation and marry the information and then come to back to the council. Pat, does that sound?
Yeah, I think that does sound, I think the message from what I'm hearing from everybody here is, I think we're in agreement that we know that we can't just put all our eggs in one basket, that it's real important that we look at this as a continuum, and that continuum goes from prevention to harm reduction to everything in between, that we can't just say our money's going to go here and this is where it's going to go. I don't think that's going to have the biggest impact on our community. I think that's the message here, that it's overview. And I think part of putting priorities and looking at things a little different is, I think when Ben does his presentation about how he's looked at how we put our money out, we really have a clear picture of how much money we have. I mean, you could say, the bottom line in 20 years, we have this, but we don't get it all in one lump sum. It's divvied out. And so he's got 3 different ways that we can stretch the money out 20 years. But in the committee, we'll look at how they want to do that. Some have upfront, more money spent upfront, others elongated out. But I think that money conversation will really start to say, all right, we have, say, 16 million, okay? How do we divide that out, evenly distributing it, or somewhat looking at prevention, treatment, recovery, harm reduction, and how do we do that? And then looking at, we wanted to, Director Squirrel's list and say, do anything on there. Again, that is and I hate to say it because it sounds wrong, they have the easier way to push things out. Right now, we're not ready to put grants out, but they are. They have contracts in place. They have all of that stuff. So, but again, it's our decision. I think sometimes we get a little mixed up that we think they're coming in and going to tell us what to do. They're bringing a presentation to us and we can put limits on it. We can decide how much, how, where. Anyways, I don't want to go over time. So I think the conversation good was today. And I think we say to the full committee that, the grants committee and program committee want to move forward, but we also want to emphasize that we don't want to fund just one portion. We want to look at this as a whole.
Yes, definitely. Okay, Liz, your hand's up.
And with that being said, I feel like to say we want to, that it's the continuum, and that perhaps the conversation is about priorities within each continuum, with each part. It's not like on what's our priority to, do harm reduction. No, the priority is that we have to do the continuum, and that it's picking the priorities within each part of the continuum that becomes the conversation, because that's when we can then pick, like, okay, if it's to expand crisis receiving centers and that's the priority, and the state has a way to do that really easily through this line right here, great, we can do it through them. But if it's something else, like having smoking supplies for harm reduction that can't be funded through the state, then maybe we need to find but that's a priority, then we need to find an alternative way to get that funding out. So to me, the priorities are really within the buckets, not fighting against each other in the continuum. Would be,
Well
I guess,
said.
like a way to sum up what I was hearing.
Well said. So let's just go back quickly to the minutes, since we have a quorum, the wonderful minutes that Chastity took. Have people had time to review the minutes? And if so, could I get a motion to accept the minutes and approve the minutes?
I make a motion, we approve the minute.
Second.
I second.
All in favor, hands?
We might have to do a roll call. I'm sorry to be that
Go ahead.
person.
Yeah. Okay, go ahead.
Here, I can do it. Second, let me grab something. Liz Blackwell Moore,
Yes.
Joe Everett,
Yes.
Pat Kimball,
Yes.
Gordon Smith,
Yes.
Keena Thakrar,
Yes.
Miles Olette.
Yes.
Motion approved.
And the last thing I would just say is that we will table we have two agenda items that we didn't get to, and I kind of thought we wouldn't. One is sort of revisiting the procurement process that we talked about last month and the TA for grantees that we started talking about. But Chastity did a great job with the minutes, so we'll bring that back to next month's meeting.
Excellent.
And with that, the meeting is adjourned.
Thank you, everyone.
Thank you, everyone.
Thank
Great
you, everyone. Thank you,
conversation.
Joe.
Yeah, thanks. Bye-bye.
Thanks, Haley.